coming in. So now we're going to hear from Pier Health, and I want to introduce our three speakers. We have Kevin Hagerty, who is the GP lead for Pier Health on the Continuity of Care programme. And then we're going to hear from Julie Davidson, who's the operations director, and she will be telling you about how she's worked across the whole group. And finally, we'll hear from Susie Heller, who's going to tell you about Tudor Lodge practice and how she's made the changes there. So I'll hand over to Kevin, and thank you again for listening.
Thank you very much, Mark. So yes, my name's Kevin Hagerty. I'm the clinical lead for this project at Pier Health. So we were based at Weston-super-Mare, a community of 9, now 8 practices, serving a community of some just under 90,000 patients. So what I want to concentrate on is why a community of struggling practices decided to prioritise increasing continuity of care. And our continuity journey really begins back in the early part of 2018 when we were identified by NHS England as being a exceptionally challenged GP communities. That's their terminology. Exceptionally challenged with regard to shortages of GPs, high workload, a long history of difficulties recruiting, and a real threat to many practices that their high GP locum costs would make them financially non-viable. So NHS England gave us some resources, some facilitation to run some meetings with the view to coming up with some solutions to our recruitment problem. So we had these meetings, and very early on we identified that our primary problem wasn't in fact recruitment. Our primary problem was to do with the working environment that we were asking GPs to put up with. GPs were working long hours very intensively and yet leaving work feeling that they hadn't done the job properly, that they hadn't met patient and that they hadn't really delivered the care that they aspired to. And that's really quite a toxic environment. It's not the environment that it's easy to recruit to. And patient demand wasn't being met, patients were getting cross, and the staff were taking the sort of brunt of that. So if we were to improve our recruitment situation, we had to address 2 issues. We had to address the workload challenges and the demand problems. So we sat down and started talking about those 2 issues. And when we looked at workload, you can see that workload is a combination really of how hard the amount of effort you put in and the number of hours you put in. So and when we discussed that, we recognized that if we could actually see more of the patients that we knew, then it takes less effort and less time to sort the patients. So simply matching patients to doctors who know them better reduces your workload, even if you see the same number of patients. And we also could recognize that if we saw patients we knew, we actually got more out of the job, that these patients give us joy in our work. And again, if you work hard but enjoy your work, then it seems like less effort. So clearly, if we were to reduce our workload, increasing continuity would be a significant help. And then we look at demand, and we could look at our practices and see that as we got busier, demand just seemed to increase. And there's good evidence behind this, that if you look at systems, a lot of demand in systems is what is called failure demand. So that's demand that is created by not sorting out the problem earlier on. So patients, perhaps because we're rushed or because we don't know the patients, they come in, we don't sort them out properly, and they come back again and again. So a large part of the demand that we were facing could be reduced if we could reduce failure demand. And when we talked about that, again, we identified continuity as being a key way of reducing failure demand. That if we know our patients, we're better at identifying the issues and sorting them out. And as Jake was talking about, continuity engenders a feeling of responsibility. So it's much easier to make the extra efforts in actually managing patients rather than focusing on the problems. Whereas if we look at systems that focus on access, you can tend to incentivize clinicians to close down consultations, to solve problems, but not to manage patients, and as a consequence, generate more failure demand. So that was a surprise to us after these discussions. The conclusion we gave to NHS England, that was one of the key things we had to do, would be to increase continuity of care. Now, we've got a shortage of GPs, as I said, so that's a huge challenge. How do you increase continuity of care in a challenged GP community? And when we looked at continuity levels in Western, they were below national norms. And what was worse, really, was that there was an inequality in those practices that were dealing with most of the more deprived populations. They had lower levels of continuity. So how are we going to do this in Western? Well, the place I think where we need to start is to ask us this question. If the benefits of continuity are so obvious, why are continuity levels falling year on year for the last 20 years? So this, what I would say, is the continuity paradox. If we could understand the answer to the continuity paradox, then we could perhaps reverse the trend. So why are continuity levels dropping in this country over the last 20 years, despite really good evidence base and despite the evidence that we know ourselves of the benefits of it? And it's, I think, to do with the fact that over the last 3 decades, we have been told to prioritize access. And we've done just that. So we've designed our systems, our processes, our culture, and we've taken on a mindset that prioritizes and focuses on access at the expense of continuity. So if you're going to increase continuity levels, it has to start with changing your mindset. And that's not easy. That's a challenge. And so what we have to do is stop thinking of continuity as the cherry on the cake. It's not a luxury. It's an essential ingredient. All the evidence base shows that there are 2 essential ingredients to the cake. That's accessibility and continuity of care. And what we have done progressively over the last 20 years is taken more and more continuity out of the cake, and it's becoming increasingly unpalatable. Certainly to new doctors, they don't want to be serving that up to patients. What we have to do is see continuity, as the evidence base shows, as an essential ingredient. Just as hospital doctors need to know and understand their diseases to do a good job, GPs who specialize in holistic, person-centered care need to know and understand their patients to find satisfaction in our job and do a good job. Surgeons need bright lights. We need continuity to illuminate our patients so that we can do a proper job. So once you've changed the mindset, really changing the processes is easy. And the toolkit offers you all the ideas that you need to do that. So what we set out to do in Western was to change our mindsets and then redesign our systems around promoting not just continuity, recognizing that you can't, in fact, provide continuity without good access. It's not access or continuity, it's access to continuity. And that's very much what our program was about. We called it Continuity by Design. And I'm going to pass over to Julie, who will explain a bit more about that. Thanks.
Thank you, Kevin. Good afternoon, everybody. Could I have the next slide, please? So our practice team, we have, as Kevin has stated, 8 practices, and what I'm going to do is talk you through the process that we actually undertake in a practice to deliver this project. It does build on what colleagues in OneCare have also already shared with you today. But actually what I'll do is I'll talk you through our process, and in that I'll try and give you a little bit of a reflection on our journey to date. And as Mark has already said on this webinar, our project will continue until later on this year. So one of the tools that we're talking about won't be available until later on this year. But I'm going to take you through the process now. So it's in 2 principal elements. One is the engagement process. One is the technical process. And I'm hoping really in showing you these 6 steps that actually this is how we undertake it in our practices. So first of all, engagement. As Kevin has described, the mindset has to be that all of the team want and recognise the needs of delivering continuity and how that's going to improve access, but also how that is going to fairly distribute the workload in the practice. So that engagement process, you literally go through that discussion with your practice team, talk about what you're trying to achieve, talk about how you're going to remove duplication, why this is a better approach. And actually, if you could just have a Kevin Hagerty in every practice giving you these are the reasons why we're doing it, I think everybody can buy into that. So it has to fit the culture of your team. And that's really step one. At that stage, what you're also doing is you're going to then look at what is the technical process, and you need to explain that to your practice team. We're going to use these tools, and this is what these tools are going to do. And so the first step of the technical process is identify the clinicians in your team, the number of GPs, and in particular, how many sessions they work in the practice every week, which are patient-facing. Because these numbers are the inputs to our what we've called a reallocation tool. And this tool, as part of our journey through this project, is something that was worked on and developed in Tudor Lodge surgery. And then we've worked with our colleagues in OneCare, in particular Jake and Julia, who join us today. And with OneCare, we've actually refined the tool as a process during this particular project. So the reallocation tool is then primed with the number of clinicians and the number of sessions in your practice every week. We then look at identifying the date that you want to adopt this. And here what we're doing is designing the continuity in. So you might decide that you're just going to put a date in the calendar and do this whole process very quickly, or you might decide to actually line it up with other changes in the practice, such as you have a GP retiring or a change of GP if they're leaving or a new GP arriving, and you've got work to do to balance the lists. So you identify the date for change because that allows you to start thinking about your engagement with patients, don't forget. So the next stage really at step 2 is really to run the reallocation tool. As has been described already by Julia, it will actually look at all of the activity of your patients with their GPs. Now, our practices are all EMIS Web, and so here we've designed things which are suitable for EMIS Web. So the reallocation tool will pull in all of the data of your patients and who they are seeing in the last 12 months, in the last few years, and up to the last 10 years as well. Because actually we do have patients who actually don't come to the surgery very often. And for us in our project, we were able to identify that some of our patients are high users of our services or medium users or low users. And all of this lends itself to actually recognising there's a workload with all of the patients. And for your GP and your clinical team, it's really important for them that they can see that their workload is balanced and that this is fair. So when we actually run the reallocation tool, it takes this data and in about 10 minutes, it will actually populate the spreadsheets from the tool, and it will tell you what level of continuity each GP has with their existing patient list. What it will also do is recognise who or which other GP is actually being seen by that patient, and what the tool would recommend would be a possible switch of this patient to this other GP because they're seeing them more than perhaps the GP who is in their usual GP field in EMIS. So the reallocation tool literally gives you a set of recommendations of what you could change the usual GP to improve continuity for your patient list. So when it's complete and it's run, you can then review the outputs. Next slide, please. In reviewing those outputs, when you work in a practice, you become very familiar with the patient names in the practice, the workload, and how people actually work together in partnership. And what you can do at this stage is reinforce back to your GP and your clinical team and your practice team what the actual tool is telling you, and therefore does that then build on the fact that you're trying to design continuity in. It gives you that opportunity to reinforce this is why we're doing it. So really now what we're going to do is recognise the journey that we went on in our practices, in that when we've run the reallocation tool, it then presents us with a list of switches of the usual GP name so that you can improve continuity for those patients. At that stage in our earliest project, and this is with Tudor Lodge surgery, you'll be hearing from shortly, what it presented us back with was a list of thousands of patients that we needed to change the name of the usual GP in the field in EMIS. And of course, EMIS doesn't give us a tool to do this. That particular step is labour intensive, it's repetitive, it's boring, and actually in practices it's really difficult to actually find the resources to do this type of job where you've literally got thousands perhaps of patients to reallocate. So at that point in our project, we then, through the workshops with the Health Foundation and other project teams, we talked with the Morecambe Bay Primary Care Collective and Joe Knight, and they said to us they had a bot of some sort that could do this switching, but unfortunately their tool wasn't something that we could use. So at this stage, we then collaborated with our colleagues Julia Martineau and Jake at One Care and said, you know, this is a real barrier for practices. How can we do this? We need to automate this process, because otherwise practices will run the reallocation tool and may then fall at the next hurdle of reallocating the patients that they needed to reallocate. So what we did through the contacts from Julia in One Care, we were able then to connect with those two people and say, here's our design. What we want to try and achieve is if we could take a source list of the names of the patients with the EMIS identity, and we want the list of names that we want to change the usual GP name to, can we automate the process to make that switch? And they said yes. What that now gives us is a working prototype which we'll continue to test for the next few months in our other practices, and it will actually do the switching for us. In that respect, when it does the switching, it does it in a few hours and can run in the background. So here, what we're saying is that the process of designing in continuity is a 10-minute run of the reallocation tool, and then you need to run the switching tool, and it can run in the background for a few hours and it will do all the changes for you. Now, the switching tool, we've engineered it so that it will actually give you a table of what it has successfully changed in EMIS, but it will leave a mark in the table against any patient record where actually the patient's record was inactive or it came across a major alert. And the reason for this is it's a little bit of a safety check, really. If you have any patients who are inactive, clearly there's a reason, so there was no point in the tool switching the name. But if there was a major alert there, we think as a practice, we want to actually check those alerts, because it could be a safeguarding thing that you want to check, or it could just be something that, you know, as a practice, you may say, actually, no, keep that patient with their original GP. There is a good reason for it. And in which case you can then go in and manually change it. But on the whole, what we think is the switching tool will take away days and days of work from our admin teams and give us something which will switch those names in a few hours, but there is a management check to make sure that you're happy with those changes that have taken place. If not, you go back and change it yourself. At the end of this process, we think it's probably not a bad idea to rerun the GP reallocation tool just to see your refined patient list, because this gives you your new baseline to work from. And at this point as well, you obviously want to go to publicise the continuity of care to your patients, to really sell that to them and outline the benefits of that. Next slide, please. Finally, once you have carried out this process, what you probably need to do is go back and just talk with staff, talk with patients, gather feedback. Are there any refinements you would like to make? And the ultimate step really is just to check any changes you may need to your policies or your protocols as a consequence of this, including where you're going to assign new patient registrations. And it's certainly a hope of our team that we can maybe combine our two tools so that we will give us something which will actually match the patients to the most commonly seen GP. It will switch them and then give you monitoring on an ongoing basis so that you can monitor where your new patient should go to. But that's just a thought for the future. So I hope in describing that, I've given you a taste of our process. I'm now going to hand over to Susie Heller, my colleague, who is practice manager and actually has delivered the project. Thank you, Susie.
Thanks, Julie. I'm Susie Heller. I'm a practice manager at one of the Pier Health group practices, Tudor Lodge Surgery. We're a surgery in Weston with 11,000 patients. So if we can go to the next slide, please. Our starting situation was significantly dissatisfied patients and staff alike. So we had not great access, well, actually it was just poor access, really poor continuity. The two things, as Kevin Hagerty said, do go together. If your access isn't very good, patients will take an appointment with anyone, and that just makes continuity more difficult. Unnecessary churn of work, where the most common complaint from the clinicians was, I've just seen a patient who was asked to come in for a review from blood test results, and I've never even met them before. So actually the quality of consultations was not as good as it could have been, and it was fraught with frustration for both people, both the clinician and the patient. And frustration was the thing that I remember the most from all parties. So we, if we go to the next slide, we had a great situation where all parties were really keen to look at a change, and two opportunities came along at exactly the same time, which gave us the opportunity to make some big changes. Actually, we had just selected a digital tool, Ask My GP, which was going to be rolled out across all of the practices in Weston, and we were one of the first people to get it. And Ask My GP was very much about continuity, actually, because it was something where you had a chance to allocate a request to a usual GP, and it was also going to change our access problems. So it was the perfect vehicle, and the continuity project that came along at exactly the same time was also going to focus on the resources really to help us make the changes. So it did feel as if we were going to go from zero to hero almost overnight, and obviously the support, the funding that we had to support the work was fantastic. We also had a fantastic data analyst who was already embedded in the surgery and understood all of the issues, and obviously understood the frustrations from the clinicians and the patients alike. And then probably the final piece of the jigsaw was that we had a deadline for launching Ask My GP, which was going to be launched on the 7th of January 2019. So I do think that that enabled us to have a really in-depth focus. A deadline is fantastic, because you've probably picked up already from the other speakers. You can look at this as a really significant project, and you can take your time over it. Actually, a deadline's really, really good. So we decided to make sure that we'd done all of the usual GP matching ready for the launch, because we were going to have a completely different way of contacting the surgery. There was going to be a lot of educational stuff for patients, lots of publicity for patients, and it actually tied it all up together. So if we go to the next slide, please. So in terms of what we did before we made those switches, the data analyst started the whole ball rolling with looking at the people who attended frequently, their ages, the equal lists with GP sessions. We are a practice with lots of very part-time GPs. Lots of people do 4 sessions a week. And we also didn't want to lose the continuity, the rare continuity that we had at the time. given that we only have 11,000 patients here, the fact that we needed to move about 6,000 tells you that our continuity was not really great and there was a lot of work. That did actually equate to well over 100 hours of manually changing patients from one GP to another. So the reallocation tool is phenomenally helpful. Many staff spent many evenings individually manually changing patients. So you know, that's a fantastic output from this project. And the learning from these initial searches and workings through of how you could apportion patients was later developed into the tools that OneCare developed in more detail to automate part of the process. So if we could go to the next slide, please. So we launched Ask My GP on the 7th of January. It was a bit of a baptism of fire, actually, because we were making this phenomenal change. We'd gone from a practice with about 15% continuity, very poor continuity, and very frustrated patients who would routinely wait 4 weeks for an appointment, to Ask My GP, which was basically a same-day sort of service. And we used the preset messages on Ask My GP to try to get patients to resubmit their request when their usual GP was working. So it did give us an opportunity to just have such a consistent message, such consistent conversations with patients and with clinicians, that it was actually a fantastic time to do both things together, because a lot of it needs a lot of explaining to get people started. So we use these messages, actually we still use these messages to try to get people used to, if your usual GP works on a Monday and Tuesday and your issue isn't urgent, please submit your request on a Monday or a Tuesday and you can expect a response on the same day. So that was quite a big undertaking, as you can probably imagine. If we go on to the next slide, please. So we had instant improved satisfaction. It was really phenomenal because the clinicians were completely on board, actually from the very first suggestion, because one of their major frustrations was about seeing patients that they'd never met before and how unproductive those consultations were. And we improved continuity immediately. We also took the opportunity, whilst we were doing two big things, we would do a third big thing, which was we realigned all of the workflow so that all of the path results and every piece of work on DocMan and path lab results were also sent to the usual GP. And one of the things that we managed to achieve quite quickly was a much better spread of work through the week. So although Mondays are always the busiest day and Fridays are always the most complicated day, we do achieve a better spread of work throughout the week. And it was a very clear and consistent message to patients. And because patients knew that if they resubmitted their request on the GP's usual working day, at least they knew they were going to get a response that day. So that did mean that we were able to allay any fears that they could resubmit their request, but then they still wouldn't get to speak to the GP for several weeks. So we had removed those waiting lists. So straight away, we got all of the outcomes that we wanted. Increased satisfaction, happier patients. In fact, patients were complaining that they sent the request in that morning and had a call from the GP 20 minutes later. So we sort of spoilt them in many ways. But it was extremely good with very little negative feedback from patients, really very little. And that was because we improved the access at the same time as introduced really significantly improved continuity. So if we go to the next slide. Thank you. So one of the difficulties in measuring, which is problematic, is that actually, regardless of what you do, it's quite a fluid staffing situation. Sometimes you hit a patch where you've got lots of continuity of GPs, and sometimes you hit a patch where you've got lots of comings and goings. So we had 9 GPs at the start of the project, but actually people came and went in the course of that 2 years. So we've only produced the statistics for the 4 GPs that were there throughout, and you can see how significant the continuity became. And you know, that shows the potential of success, but you do have to recognise that there will be changes, and GPs will change the number of sessions they do, or I'm sure that's pretty common and not just at my practice, but that does throw a bit of a spanner in the works, because even when you're recruiting a new GP, in my experience in the last 7 years, it's almost impossible to get a new GP to do exactly the same number of sessions as the previous GP did. And of course, we're bringing in other healthcare professionals as well now. But we were really, really delighted, as you can imagine, with the levels of continuity that we achieved quite fast. If we go to the next slide. So the next slide just shows the sort of averages of continuity, given that we were looking at individual people that were there throughout, but this is a more broad map of the continuity that we were doing. And given that number of changes of staff throughout the period, we achieved far better continuity than we thought. We also thought that having GPs, lots of GPs only doing 2 days a week would have been really difficult, but it actually wasn't. I think once the patients get to know the GP, it's something that they value very, very highly. Next slide. So in terms of how we feel looking back in terms of next steps, well, of course, the changes of staff haven't stopped, and we've now got more advanced nurse practitioners and more paramedics. We've got different clinicians. So we do still have challenges ahead in terms of measuring continuity with different clinicians. And we do need to make some decisions about how we go about this. Are we going to go for usual GP because that's what the field says in EMIS, or are we going to try and say usual clinician? Because we don't want the GPs to feel that they have an unmanageable number of patients on their list. But we are in a lucky position now, because although we've done this once, you do have to keep on top of this, and although we've had fantastic success and we love continuity, we are going to be using the actual tools again for a second reworking of this, and I think everyone should expect that this isn't a one-off process. You do need to repeat it in the future, because staff do come and go. And then the last slide, I think the next one. Very positive. I don't think there's any negative things that have happened as a result. There are challenges with people coming and going, and there are challenges with new types of staff. We firmly believe that care to patients has improved. The consultations are just so much more efficient, and we certainly don't hear complaints anymore from the clinicians about being sent the results of a patient that they've never seen before, unless it was an urgent result. We are absolutely committed to carrying on with continuity, and we're going to be reworking the searches reallocation tool, and it's something that we would never go back to how we were before. We're just delighted that we had the chance to do these 2 big things at the same time, because it set us on a better path. So there we are. I think we're going back to Mark now. Finished talking.
So thank you very much indeed. Sorry about the microphone noise we had just then. But thank you to Kevin and to Julie and to Susie. Really interesting to hear the progress and success you've had, and fascinated to hear about the failure of care demand and the continuity paradox. So it was great. Now, I'm aware that some people may need to leave at this point, and just to remind you that this is being recorded, so you can look back over the sections you want to. And what we're planning to do is continue on with the question and answer section. We're just collating the questions at the moment in the sidebar. But what I want to do just is thank everybody again, particularly all the 5 sites. I want to mention again Exeter St Leonard's for their continuity measure and for the evidence base they've created and their work in the literature. I want to thank Morecambe Bay Primary Care Collaborative for all their work on the organisational level reallocation and switching tool and the GP toolkit, and of course Valentine Healthcare, who've completed their project and have managed to show an increase in continuity of care and have looked at micro teams and frequent attenders, which we might talk about in a minute. And thanks, of course, also to the organisational power behind us, Liz Kramalski, who's been doing all the IT and sorting that out on behalf of the RCGP, and Angus Wiltshire, Jenna Collins, and of course Candida Pereira, who you heard earlier.